with the references. So at the outset, I want to thank Dr. Vanchi sir for this opportunity to be part of DiaObecon. And indeed, just staying in the flow with the theme of this conference, which is History of CGM. I'm going to just take a minute to take you through how beautiful the journey has been of development of CGM. Right from 1999, when the first CGM came in, which was Minimed Professional CGM, which came up at one of the first ones. Then came 2006, a kind of miniaturized CGM, the kind of CGMs what we use now started to appear. Then came Abbott's versions, then Dexcom again came up with a very unique version of it, and so on and so forth, and where we are today. So let me take this on a more beautifully crafted slide, which has more pictures. So this is the first CGM, which was there, the history, how it started. Then we had a gluco watch, which miserably failed. It never took the stand of time into the clinical care. Then came first wireless CGM, which was Medtronic Guardian. Then we had other versions coming in, and then Abbott came in with Navigator. Then again, Dexcom came with a miniature one. Then came G4 Platinum, and then G5 came, which was world's first mobile synchronized CGM. And then parallelly, the insulin pumps were also getting innovated, as we heard, and so on and so forth. It continued to evolve. Now, let me step into my topic, which is significant TBR, time below the range and avoiding hypoglycemia. So this is going to be a case-based discussion, and it won't be too much of a theory. 101 million deaths, million adults with diabetes, that's close to 11.1% population, and each hypoglycemia costs anywhere between 45 to 75,000 in a private setup, the admission or any expense you take. And 74% of patients modify the insulin utilization due to the hypoglycemia concerns, which is very surprising. So my session today is going to focus on three key aspects, which is why time below the range, which is the hypoglycemic zone, matters. 5 real cases, with which how we can enhance your care, and again identifying the real TBR. So as we heard from the previous 2 honorable speakers on how important it is to look at the nitty-gritties of CGM, sensor parameters and other aspects, I'm also going to showcase you a few other pointers. So why TBR really matters, as we saw in the last chart by Dr. Manoj sir, there's a clear-cut bifurcation of 2 levels of TBR. The level 1 is below 70 mg per DL. On a sensor, the level 2 is between below 54. So basically, the level 1 is 54 to 69 mg per DL, to be more specific. Level 2 is less than 54 mg per DL reported on CGM, which is a clinically significant danger. And the ideal target, or rather aim, is to have all our patients have time below the range less than 4% of 24 hours, which is just 60 minutes. तो 60 minutes से ज़्यादा 24 घंटे का समय, patient should never be on a sugar less than 70. That's what we want to accomplish in our care side. Yes, and why it's dangerous, we are very much aware about the cardiovascular, neurological, as well as the quality of life derangement hypoglycemia does. I'm not going to delve into a little deeper on that. But one thing I would like to share is about cognitive connection with hypo. 56% increased dementia risk after one single severe episode of hypoglycemia has been observed, and the risk doubles when there is recurrent episodes. So let's start with the cases. Let me take you to the first case, which is nocturnal dance of sugars. Yes, that's the first case which I've titled it. So let's look at the patient profile. This is a 52-year-old female patient, a type 2 diabetes patient, 12 years diabetic. The current HbA1c is not bad. It's 7.2, not really bad. And the regimen is a classic glimepiride with metformin, and the person is on NPH at 24 units. And that's at 10 p.m. the patient is taking. Fairly common, we see this now and then. The presenting concern is night sweats, morning headaches, but the fasting sugars are 180 to 200 range. So there's an adequate dinner and evening snacks as well. ऐसा भी नहीं कि रात में गुल्ली मारा patient. The patient is eating well, properly fed. The AGP interpretation is the time below range is 8%. So that's close to more than 120 minutes. 2 घंटे से ऊपर का समय 24 घंटे में the patient is spending in low sugars. This is what the AGP interpretation is showing. And between 2 a.m. to 4 a.m., which is the night, the first जो पहला काल रहता है रात का, in that time span of 2 to 4 a.m., we are seeing a consistent hypoglycemic variation. And the net coefficient of variation is 41% across 24 hours. So let's understand, what does this translate? Actual clinical sense kya hai iska? So we are seeing a 10 p.m. Bedtime sugar also to be fairly stable. It's not that bedtime pe down ho raha hai, right? So till 2 a.m. we are not seeing any low sugars. But at 3 a.m. we are seeing the peak low, which categorized into level 2, time below the range of hypoglycemia. And then again, there's a counter-regulatory rebound at early morning, what we are seeing at 180 to 200. So here, there are 3 differential diagnoses. It could be either a Somogy phenomenon, which in this case is confirmed by the 3 a.m. Report, what we are seeing, verified with the SMBG. Down phenomenon is not possible because it requires a normal 3 a.m. glucose, because this is just a plain rebound hypoglycemia. And there's no history of insufficient evening snack. The person is already eating well in dinner, right? Now, looking at the therapeutic aspect of this, the NPH PKPD, as we all know, it peaks at 6 to 8 hours. And that is one of the possible trigger of this low sugar happening. Glimepiride and NPH is a bad marriage. We don't want this to continue. Counter-regulatory response masks the underlying hypoglycemia development time. Though we are seeing 3 a.m. as the hypoglycemia, the initiation of hypoglycemia may be happening at around 1:30 a.m. But because of this masking response, the initiation symptoms are missing here, and the person is going as low as 45 to 50 range, right? Which otherwise at 70 should have triggered some symptom like neend khul jana, which is not happening in this patient, right? So here there's an opportunity to protect the cognitive function. So the immediate action is to optimize the NPH. Later, a weak factor, we could shift to a more stable insulin, a more peakless insulin, something like degludec or a U300. And again, establish a proper bedtime protocol for a snacker. And then again, optimization of oral drugs, considering a shift to a GLP-1 or a DPP-4 or a metformin combination with the other two, or a GLP-1 as well. So when in this particular case, the shift was made to degludec and the shift was made to an SGLT2 GLP combination, and the TBR went from all the way 8% to less than 1%. And also along with that, the SGLT2 stabilized the fasting fluctuation as well, which got the patient to a stable fasting sugars. So, and without saying, the quality of life of patient was forever changed. So let's understand what's the difference between DAWN and Somogy from CGM perspective, not from theoretical perspective or conceptual perspective. A simple aspect which you can differentiate the two is at 3 a.m., a low sugar, if it's there and there is a counter-regulatory hormone triggering a rebound, it could be possibly Somogy. But if you see a normal or a high glucose at 3 a.m. and there is morning rise, just plain morning rise when the person is waking up from the sleep, it could be a DAWN phenomenon, which is triggered due to cortisol or growth hormone or any other factors which trigger it. So what are the solutions? In Somogy, it's actually, you are supposed to reduce the basal insulin at the night time. But in DAWN phenomenon, you are actually supposed to increase the basal insulin or shift the time of your basal insulin. This is the key differentiator. And all this is from CGM learnings, friends. Now, let me take to the case number 2. A proactive athlete, an athlete who is looking for a performance optimization of sugar control and fitness both. And this is a type 1 diabetes case, 35 years old female, 15 years diabetic, a very competitive athlete, on multi-drug insulin therapy, degludec and lispro, already good combination, right? Training schedule, 6 to 8 p.m. is the resistance training what the person does, and on weekend, the person runs on multiple short marathons. Here, on exercise days, the time below the range is 10%, which is close to 2 hours, 40 minutes of 24 hours. The person is spending in low time despite being on a good basal bolus regimen and maintaining a fairly decent, regular schedule of fitness and the lifestyle. And here the coefficient of variation is 38% on exercise days and 28% on resting days. So ऐसा भी नहीं है कि resting day पे variation कम है. Even on the resting day, you're seeing a very high variability of 28%. So when we did the trend analysis of the CGM report, the pre-exercise 6 p.m. sugars, evening, was somewhere around 150 to 160. The immediate post-exercise was somewhere around 130, 140, still fairly okay. But at 10 p.m. to 12 a.m., the early post-dinner or rather bedtime, there was a major drop in sugars. Friends, this is not midnight. Midnight nahi hai. This is bedtime drop in sugars. And again, it was continuing. It was continuing to go low till 3 a.m. Now here, what could be the differential diagnosis? Immediate exercise hypoglycemia, it was absent because immediate post-exercise was somewhere around 130, 140. Delayed enhanced insulin sensitivity was the factor here. Because friends, when we exercise, even for a type 1 diabetes patient, the muscles are stimulating the insulin sensitivity, right? So, and then there's an inadequate recovery in nutrition, which is a contributing factor. So GLUT4 upregulation persists 24 to 48 hours after exercise. This was the learning from this session. Enhanced peripheral insulin sensitivity also continues. And empowering athletes through precision insulin management here is what really changed the trajectory for the patient. And the dinner bolus was adjusted here. 30 to 50% reduction in the bolus on training days was done. A basal modification of 20% reduction was considered here. And recovery nutrition was added here, so that the delayed hypoglycemia of bedtime could be prevented. And this was, friends, a complex carbohydrate, not a refined carbohydrate, which was added for the patient. And the CGM optimization, predictive alerts were set at 90 and not at 70, so that there's a window of 20 mg per DL stabilization which is possible. So with this, the outcome was TBR reduced drastically from 10% to 2%, and there was a sustained athletic excellence with the metabolic safety. So with this, I complete two cases. There are two more, but I think in paucity of time, we'll surpass it. Right, so with this...
In case you can take more.
One more? Yeah. Sure. All right, so let's take a case of, I'll take one case of fasting, Ramadan. So this is a case of sensitivity in care, a case of Ramadan observer. A patient, 55-year-old female, type 2 diabetes patient, 10 years, Ramadan observer, was on glimepiride, metformin, and sitagliptin at peak doses, full doses. Again, the AGP during fasting, here what was observed was the baseline time below the range was 2%, but during the fasting period, it was going as high as 18%. So that's close to 20% of 24 hours, the patient was in low sugar. So 1/5 of 24 hours, patient was spending in low time during the fasting periods, as in fasting, during the Ramadan fasting. And post-iftar, the sugars were very, very high, 300 plus, which was not the case in a normal day. So here, the glucose dynamics were like in suhoor time, which is typically the early morning. It was somewhere around 120. The afternoon variability was somewhere around 45 to 60. And evening, when the fast was broken, it was somewhere around 300 to 350. And this differential diagnosis, what we could come up for this particular case was, there was a medication fasting mismatch. A feast-famine physiology was getting triggered in a patient's body. So again, what we did an optimization of medications. We shifted to SGLT2 and metformin at suhoor. That was first change. And at iftar, we shifted on sitagliptin with adjusted dose of metformin. And CGM monitoring was thoroughly observed. Again, medical education was given in terms of how to split the evening. When you break the fast, how do you split the meals? That's very critical here. And again, outcome was a safe fasting period. The time below the range went down from 18% to 3%, and again, both aspects were covered. So you can just take a picture of this. These are some few other cases which I couldn't cover, but this is like a summary of pattern recognition. How do you recognize a CGM trend pattern? And what could be the immediate solution? What could be the context of our patients? And how do you plan the long-term safety in terms of therapeutics when you get these cases? So with this, I come to an end of my session with just a last slide. These are the few pointers. Again, you can take a picture. 3 a.m. nocturnal, 12:30 p.m. midday, 5 p.m. afternoon dip, and post-dinners. These are the key factors which traditionally get missed out even in an SMVG or rather a conventional fasting post-breakfast scenarios. So when you're starting to use CGM, start looking at these windows to find things which may be transforming your patient's care. I'll not go into this deep. This has been covered by my fellow speakers. So this, I come to an end. And there we go. This is my last slide. So in a nation with 101 million diabetics, every percentage reduction in TBR enhances lives. And let's have an excellence equation. No patient should get a time below the range of more than 4%. So with this, I end the session and take forward to the speakers.
Yeah, thank you much.